The program manager. All right, great. Hi, everyone. Welcome to Dialogue with Khuraira. If you're new to this platform, Dialogue with Khuraira is a platform where we celebrate individuals we call the unsung heroes. Why are they the unsung heroes? They are great people doing amazing things in different communities, but maybe the spotlight isn't on them. You may not hear about them. So we find them, we bring them to our platform, they share their story, how they were inspired to start what they are doing. Hopefully, you will be inspired as well and start something. That way, we will save many lives, one person at a time. Today, we have two Haleys. We have Hayley Dinerman and Hayley Brown. Hayley Brown is here in place of her mom, Nikki Brown, but she is also part of the organization. Actually, I think she is the engine room of the organization, of course, with her mom. And then we are also going to have Dr. Alhassan Umar Adamu later, the chairman of breast cancer. Nigerian Cancer Society. So he's going to be joining us later. We usually do 1 hour, but today we are going to do an hour and a half. And we're going to first go with Hayley Dinerman. And welcome, Hayley Dinerman, and welcome, Hayley Brown, to Dialogue with Khuraira.
Thank you so much for having us, Khuraira. I feel like I've known you forever, and you've known me since this foundation, was just in its infancy, and you've been a supporter ever since we started. So always thankful for you.
Yes, thank you, thank you. It's always a great thing to have people that share the same a passion and mindset in bettering the lives of others. And Hayley, I cannot say thank you enough for always remembering to call me upon whenever something is needed. And I will barely say no, even if I'm not going to be there all the time. I will always would want to. So Hayley, we're gonna start with you. I know you have another engagement in like 30 minutes, so we're going to have you please introduce yourself. I know your bios are there, but you know how people are; they barely read. So you talk, and then after you're done with your bio, I'll ask you questions. And then, of course, if there's something else like Hayley feels like jumping in, can do. And then after you, Hayley introduces herself. We know the drill. Like you guys have done it.
I got it. Thank you.
Good.
Yes.
So I am Hayley Dinerman. I am a co-founder and the executive director of the Triple Negative Breast Cancer Foundation. It is a foundation we started in 2006 in honor of one of my closest and dearest friends, Nancy Zena. She was a young woman in her early 30s when she was diagnosed with triple negative breast cancer. And like most of you probably watching today, when I first heard the words triple negative breast cancer, I was surprised. I didn't even know that there was more than one kind of breast cancer. As far as I was concerned, there was one type, and no one that young that I had ever heard of was ever diagnosed with it. But I got educated quickly, and myself and Nancy's other friends and family, we banded together and we tried to figure out where she can find support. And back then, and this is back in 2006, there really was no place to go for triple negative specific support. And so we decided that we were going to start this organization in her honor, and it's been her legacy ever since. And so I think I should start, since I didn't know what triple negative breast cancer was, I think I should start by explaining what it is and then why we're here and what we do. So, sure. So triple negative breast cancer is an aggressive form of breast cancer. It is most breast cancers have certain receptors, HER2, estrogen, or progesterone. And most of the treatments that we think of as being super effective in controlling breast cancer target one of those three things. With triple negative, the tumor is negative for estrogen, progesterone, and HER2. So back in the day, there were no targeted treatments to control the tumor, and it would just spread. Now, fortunately, we have some targeted treatments, especially in the metastatic setting, and it is no longer the untreatable disease that it once was. It is still aggressive. It tends to target certain populations more than others. Black women in particular are disproportionately impacted by triple negative breast cancer. And I think that's why it's so important for Black women, especially young women, right? Because no one has breast cancer on their radar when they're in their 20s. But
Yeah.
if you do catch it early, you can get treated. There are treatment options now. And I speak every single day to long-term survivors. So it's so important to be educated about this disease. It's so important to check your breasts, right? The other Hayley will talk a little bit more about that because she's a big proponent as well. And we work together. The TNBC Foundation works with other incredible organizations to bring not just awareness, but practical solutions to women and especially Black women with
Yeah.
triple negative breast cancer. You can find us at tnbcfoundation.org. We are also, together with Hayley and her group, Touch the Black Breast Cancer Alliance, we're going to be launching in the next month or two a website, an online hub that is specific for Black women with triple negative breast cancer. So it will be like the go-to place
Amazing.
for
Amazing.
information and resources for Black women in particular with this
Yeah.
disease. But that's us in a nutshell. I'm happy to take any questions you have after.
Yeah, well, amazing. I know, I would say you mentioning of Nancy. I remember the first day I met her was when you brought her. I think she was doing the first event when she was about to launch the foundation, and she needed her makeup done, and you brought her for me to do her makeup. I have to tell you, Haley, I've met two women in my life that were diagnosed with breast cancer and are told they are dying, but they carry themselves so well, like that nothing is wrong with them. When you had her, then I don't know she had cancer, until later on, when you later on told me, you remember when I brought her this, I'm like, oh my God. And the same thing with Leslie Simon's foundation in Inglewood, the same thing. She was a client of mine. And women are brave when they are faced with. I don't know if I can um, be that brave, but these two women have really touched my life. That since then I'm committed to like doing something about breast cancer, cancer in general, because especially as you mentioned in the Black community, it is something that the awareness is not there.
Mhm.
It's not really out there. I know you guys have done a lot since then, but we still need more. And it is the reason why I made sure the president of Cancer Society of Nigeria is part of this program. Dr. Alassane Umar Adamu, and he's a doctor, to be part of the conversation and see, who knows, that maybe the three organization will have something that you can do to reach as many people as possible. So, Haley, I know that you guys have done incredibly well. You've touched so many lives, raised money, and talk about the trials. That I read somewhere where you guys are really involved in doing trials in this kind of disease, and of course, including the awareness. What kind of trials, and uh, do you get your how do you get the patient to participate in the trial?
Yeah, I can jump in here.
Okay.
So my name is Haley Brown. My full name is Haley Brown Buxton Punch. We're gonna keep all my names. Got married last year, but so I'll kind of just tell my story a little bit too, just to like dive into how
Yes,
we got
yes,
here.
it's very important.
Um, so my mother was diagnosed when I was 19. So a lot of the young women efforts do come from that as well. But I actually had a great aunt that had breast cancer, a grandmother that had breast cancer. Grandma's still 91, had a little, her breast cancer was actually stage 0, got really lucky, lumpectomy, and she's 91, still bossing us around. And then my mom got breast cancer, and she had triple negative. I believe it was stage 3A or 3B. And she immediately like didn't really know how to stop being Ricky, and didn't know how to stop didn't know how to slow down. And so she had chemo, radiation, all the things. She had to go through the entire process for about a year, at which point it came back. And she went to Dr. Google. I'll tell her story the way she tells it a little bit. Went to Dr. Google and really couldn't find any resources for Black women with triple negative breast cancer. But that is then when she found Hayley Dinerman.
I know that's a great story to share, because isn't she in Texas? Your mom? Are you guys in Texas?
No, she lives in Maryland. She lives in Annapolis,
okay,
Maryland.
I know it's not in New Jersey.
Yes,
exactly.
During this time, she's moving to the beach, divorcing my dad, and quitting her job, starting her own companies, just like really rechanging her life, because she really says that her stress got her breast cancer. And so at that point, I probably became an advocate for a while, but didn't really know what it was like, didn't really understand breast cancer myself. I wish the doctors had said more to me about genetic testing and things back then. But about 2 years ago, I guess, I started working for my mom. And so now we are really the face, I believe, of Black breast cancer. And I would be then Black breast health in that way. And so we offer so many services for survivors. We have support groups, web series, 6 campaigns. My mother says no to anything. This doesn't say no ever. The answer is never no. It's always how, she says. So we're going to figure it out and figure out how we can support Black women, because we have a 41 higher percent mortality rate than white women, and we have a 39 higher percent recurrence rate than white women. And so it's a dire situation for Black women, actually.
Yeah.
The clinical trials. So we did like a giant research study, and then created this campaign called When We Trial. And this campaign has now signed up over 20,000 women for breast cancer trial portals. So that doesn't necessarily mean they're in trials, of course, but it means that we've changed their mindset around trials. And we do that by really creating lots of video content, because that's, again, how Black women are receiving information. And all of this is very data driven. We have advisory boards for every program, and we run everything by the community. So we make sure it's really community oriented, and really reaching people and, meeting them where they are. We go where Black women live, work, play, pray, and slay, my mother says. And so we are everywhere. But it's fun and it's important, and we try to be like innovative about how we do it. We have bathing suits for my campaign. We have all kinds of things to really go where Black women are and relate to them in a really fun way. But the clinical trial campaign is amazing. It's been going really, really strong now for 2 years. We now have added like nurse navigation, integrative care, also work with many partners, just like Hayley Dinerman, just to not reinvent the wheel, because we just want to connect in that way. Just really use each other's expertise to make to reach everyone, And now I feel like we are really first that mindset switch. Now we're getting to the behavior change, and things are changing. We are a part of trials in a more intentional way, and so we're definitely getting it done. Well, getting shit done, my mother would say, actually. Sorry, that's not a great audience.
So with these trials, do you have like particular centers they go to, or how does it work?
Yes, so we are actually working with now 2 and maybe almost 3 pharmaceutical companies, and actually written into their IRBs. So like we have to be a part of the trials, or we have to be a part of the advocacy. So we rewrite the information so that it makes sense to Black women. We take out the bigger words and make sure it's all in words that you can spell and relate to. I love that we say it's not about being in the science in that way. It's about seeing another birthday, seeing another graduation. We change that language so that it matches, a narrative that we can relate to. And again, then we have video content of blesties explaining this to other blesties. So you're seeing it from Black women. And our nurse navigation is from Black women who are blesties. So, right. So they're really integrated in that. They know what it's like, they can relate, because you really don't know what it's like if you haven't.
And especially people are afraid whenever they hear the trial, especially in Black communities. It's like, oh my God, they're going to go put something for me and kill me anyway.
And that's not the case anymore. You're going to
Yeah,
get
it
standard
is.
of care. You're
Yeah,
going to get more screening. You're going to get better attention. You know, driving to the facility. There are these resources that we have to share because we have rules and regulations to avoid the historical elements of clinical trials for Black people.
yeah,
Right? And that's in cancer research. There's there's like no more placebo in cancer research. You know, so you're going
There's
to
no
get
sugar pill. There's no sugar pill. There's
yeah.
nothing like that. And I think that that's a big misconception.
okay,
And it's what's held so many people, especially Black women, back from participating in clinical trials. And, you know, I've been doing this work, like I said, since 2006, and I've seen many organizations come and go and try to make an impact, but I have never, ever seen an organization like Touch and what Ricky and Hayley are doing make, you know, such enormous strides in such a short amount of time, changing people's minds, educating people, and making them understand the benefit to them of clinical trials. It's
yeah,
incredible.
yeah, it
Yeah.
is. It is. And then in the Kelly, you are here in New Jersey, so
No, I live in DC and New York
I'm
currently.
talking of Hayley Dinerman.
Oh, gotcha. Yeah. And that's hilarious
There's two
because I
Haleys.
should. Yes. Well, I'm from New Jersey, so it's like I moved back to New Jersey.
So you, Haley, you're in New Jersey, and you know, like people, especially when it comes to, of course, Maryland too is another international destination for women, Black women that don't live in America.
Mhm.
You know, so if somebody watches this program and they want to be part of the clinical trials, and how do you guys direct them if they are coming abroad or they're in an international waters, but they want to be part of this because it's not being done there. But I'm sure Dr. Allison will let us know if they're doing any clinical trials as well on triple negative breast cancer or breast cancer as a whole. But I think the one that you guys are focusing on is the negative breast cancer, right?
Well, we focus on triple negative,
Okay.
and Touch focuses on all breast cancers that impact
Okay.
Black.
Okay. Okay. Wonderful. Wonderful. So you being in New Jersey, how do you you know, you're in a bigger space in New Jersey, New York, Philadelphia, and Connecticut, all, you know, it's right. We're almost like in the same city, you know. So if people are to come here, do you guys have a place or do they just register online? How does it work? That I think because we have to break it down to like a layman's
Absolutely.
language. Yeah.
It's actually a pretty streamlined process.
Okay.
So there are clinical trial matching services. They're free services. You go online, you can find two of them on TNBC Foundation's website. But again, as Hayley, the other Hayley, mentioned, When We Trial is a phenomenal website that connects you with clinical trials that match the criteria of the disease that you have. It also will, once you plug in your information, it will also, you know, spit out which centers offer this particular trial so that you have a place to start. Your doctor, your medical team, that's who you should always start with, has
Yeah.
a place to start.
Okay.
And so many of the trials do have international locations as well, where once you found out what trial it is, you were able to coordinate with your doctor, with your medical team to find that type of treatment
Oh,
where you are. You don't necessarily always
you
have
have
to
to fly.
travel.
You have to fly here to do it. So you can do it even from where you are and see if you are fit. So let's say if that person is a fit for that trial. What is the next step?
So the next step is for your medical team to connect you with that trial.
Okay.
And it's not a simple question. I'm sure Hayley would agree because
Yeah.
every trial is different. They have different standards and criteria. Some trials are only being given at one center, some at multiple centers, some internationally, some only in the US. So it really depends what you qualify for
Yeah.
and what your medical team feels is going to benefit you. I think the key thing, though, is for women to go in.
Hassan, can you mute your camera? Can you mute so that until your movement is interfering with the? Okay. Yeah. Thank you. Thank you. Go ahead, Helison.
I think that the key thing is for women to advocate for themselves, because so often, and I know Hayley's research has shown this as well, that doctors don't always, talk to you about clinical trials, right? And sometimes, it shouldn't be up to us as women to bring it up, but sometimes you have to advocate for yourself. So knowing the importance of clinical trials, knowing that you might be getting the best care in the world by opting for a clinical trial, as opposed to just not even considering it, you should bring it up with your doctor. And once you bring it up with your doctor, they will be able to also guide you, in terms of, where to look. But you should know that, again, organizations like Touch and their When We Trial website and TNBC Foundation, we have two, clinicaltrials.gov. That's a third one. So there are places to go. And once you have an idea of which trials you might match with, you have to go back to your doctor and say, hey, I'm interested in this. Can you help me?
Okay. That's wonderful. And then the doctor can do all the paperwork, your blood work, what have you, to send. Well, clinical trials are really, like you said, you get the best care. Hanif, my son Hanif, he doesn't have sickle cells. He is a clinical trial,
Yes.
And believe it or not, he's now working with the team, part of another clinical trial. And Hanif is patient zero of this clinical trial, that he was saved. And many other children have been saved since his 10th year. This is his 10th year anniversary. So it really does work. And the doctors actually give it its all. People feel like that the clinical trial, I think in the mindset of people, is that this is not being tested, they're just testing me. No, I think, explain more, doctor. You, the doctor, you can explain to people that when I guess they think that your heart trial is that they are trying it on you. It never been even the formula or anything, right? I'm sure the doctor have done all the work. They've tested. They know it wouldn't harm you, right? Or am I getting it wrong? I think, to me, if you tell me that is actually myself, that is what I would be thinking. That
And
you
I
take.
think it's important to remember that, like, everything that we use was in a clinical trial, right? Every medicine that we've ever taken, every Advil, every, like, that's what innovation is. It's like trial and error. That's exactly how you create, right? And I love when my mom calls clinical trials the drugs of tomorrow. It's like, it's the best stuff.
Yeah. So, Dr. Alassane, you wanted to jump in and say something. I hope your network will allow you. And here is Dr. Alassane Umar Adamu, and he is the president of the Nigerian Cancer Society. So, I'm so excited that you three are together, because I know after this there will be an amazing collaboration that will go into this and share a lot of, because also you need the data. Data is very important when it comes to trials or even treatments. Anyway, welcome, Dr. Alassane.
Thank you very much. Can you hear me?
Yes, we can hear you.
Oh, fantastic. Thank you very much. A very good evening over here, and I want to believe morning to the ladies over there. It has been a very fantastic. Is it afternoon, right? Afternoon, yes. Okay, 4:30. All right. Fantastic discussions ongoing by the two Amazons you have in the room. And I must say, I'm highly impressed. I'm highly impressed by the quantum of energy, the quantum of knowledge coming from these women. Now, the beautiful thing, or let me say, not so beautiful actually, with breast cancer is the fact that it is one cancer that we all have to pay attention to, not only those of us that are over here in low and middle income countries. Everywhere, all over the world, breast cancer is the number one cancer. Yeah. And of course, when you're talking about the Black population over there in the US, the preponderance of breast cancer is equally, rampant. And again, I am happy one of the Haleys is working on all forms of breast cancer, and the other is working on triple negative breast cancer. Of course, triple negative breast cancer is the most aggressive type. It's the one that rapidly grows beyond the imagination of the patient or beyond the imagination of the doctors. And how do we tackle cancer? How do we tackle breast cancer? Research is the key ingredient that generates data. And that is why I'm very happy to be in this room today, hearing or listening to these beautiful depositions from actors on the field, advocates, and of course, clinicians, because whoever is into clinical trials, whoever is into research is equally a clinician. And that is one area that we are far, far behind over here, in places like Nigeria, in low and middle income countries generally. There is, we have a professor of radiology in Nigeria, founder of one of our NGOs, Breast Without Spot, in Enugu. I'm sure probably you must have heard of her, Professor Emeritus Ifoma Okoye, and she's doing very well in the area of clinical trials. She's part of the African Clinical Trial Consortium. But just like Khuraira said, when people hear about trials, they think it's trial and error.
Yeah.
But I'm happy Hayley Brown put it very well, that in fact everything we do, in fact the food we eat is also a clinical trial. So basically, and trials are the best solutions, to get cure, are the best solutions to get the best of cure. And I'm very comfortable and happy that this discussion is taking place. And I want to believe that we are going to build on this. In fact, recently, I was appointed as a national committee chairman of the Nigerian Medical Association Committee on Oncology and Cancer Care. And already we have started developing proposals, to carry out quantitative research, not qualitative, quantitative research on, of course, knowledge, attitude, practice, and behavior, on community oncology, on the various perceptions of people towards cancer. And that is the beginning of what will now ultimately get us to go into clinical research proper. And we are already in talks with the Sylvester Cancer Institute and the Mayo Clinic in US. And just recently, I had
Mayo Clinic.
Yes.
Yeah.
Just recently, when I was at the World Cancer Congress in Geneva, I had a meeting with the American Cancer Society. Okay. And I am happy when I entered this room, Hayley Brown was talking about patient navigation.
Okay.
Which is a very major component that is a serious issue in places like Nigeria. Patient navigation is a major issue, and I'm happy American Cancer Society is working on bringing, support to, African cancer organizations, to carry out patient navigation projects. So, and that is what will, because it's only when the patients come out, it's only when the patients know where to go and get care, where to go and get the best of treatment, that he or she can be exposed, to options like clinical trials, to options of participating in research. Because without research, we will continue to move in cycles.
Okay.
Hold on
that on Dr. Alassa, because I know Hayley has another appointment, and I just want her to just tell us, Hayley Dinerman now. I will be left with Hayley Brown and Dr. Alassa here. So Hayley, so far, with the clinical trials you guys have done, with all the outreach and all the advocacies that you have done, what did you, especially in that Brown community, what was most challenging for triple negative breast cancer to really penetrate into that those communities?
Well, I think in the United States, there is, because of history and because of the way the Black population was treated in the past when it comes to medical experiments and things like that, there is a very justified mistrust in the community when it comes to thinking about, clinical trials and participating in medical research. But because of that, it's almost like all drugs that come out have such a small representation of Black people in the trial. It hasn't been tested on Black bodies. And so how do you know if it's going to be as effective? How do you know how it's going to, impact your life? That's why it's so important. And I think no one has put this message out there better than Touch. That is why it is so critical for Black people to be interested in and in clinical trials. So what do I think was the question? What do I see? I think that was the main obstacle.
Yeah,
changing people's minds about it, because people still think that there might be a sugar pill or you're going to be a guinea pig. They don't know, and I don't know that I would have known this before doing this work, that at the bare minimum, you're going to get the standard of care. You're not going to get less than you were entitled to, but you might get more. You might get the cutting edge treatment that isn't available to everybody else.
Yeah.
And that might be the difference between you having a positive outcome or not. So that's
what would you say the success rate is
for
most of the clinical trials that you have done? How successful?
We have not, we connect people with clinical trials.
Yeah.
So as an advocacy group, we don't conduct clinical trials. And there have been, there been trials that have been extremely successful, which is why we now have FDA approved drugs, right? And approved therapies for both early stage, but mostly for metastatic disease, and so many ongoing trials. So there has been much success. I remember when Nancy was diagnosed back in the day, TNBC was considered kind of a death sentence. I mean, so few people would survive it. Now, every day I speak to women who are 14 years out. Do you know what I mean? So that all started with clinical trials. That's how that happened. There weren't these therapies, and now there are immunotherapies now that didn't exist before. There's so many different options. And before I leave, I do want to say that Nigeria is not neglected in the sense that there are so many brilliant scientists, and I'm sure the doctor knows some of them himself, that are doing very important work in breast cancer, and even specifically in triple negative breast cancer in Nigeria. One of them sits on our scientific advisory board, Dr. Lisa Newman. Hayley knows, is doing, has done tremendous work on the continent as well.
Oh, wonderful. Last question. Is triple negative breast cancer hereditary?
There is a component that is genetic.
Okay.
So if you have a BRCA mutation, for example, your probability of getting triple negative breast cancer increases, right? So, but that is not necessarily, that's not only in Black women, right? So Angelina Jolie, for example, had a BRCA mutation, and that's why she had a prophylactic double mastectomy, because she wanted to reduce her chances of getting it. But there is a hereditary component, yes.
Yeah. Okay. Well, Hayley, I know you have another engagement. Sorry, I kept you past your 4:30. Thank you so much. And I am sure this is not the end of the conversation. The three of you, my prayer, will be working together and saving lives one person at a time. So, Hayley, thank you so much for being with us, and good luck with everything. Thank you.
Thank you so much for having me.
Yeah, no problem. Okay, so now I have Hayley Brown and Dr. Alassane.
And I want to jump into, I was actually the Hayley that had to leave early.
Oh, no!
Yes, but it's all good.
Yeah.
But I know that what a common misconception. So if you, but there are so many things I want to say, because so many amazing things have been mentioned. So and again, my mom found Hayley Dinerman because she found Triple Negative Foundation. Hayley connected her with correct doctors in the country, so she could be here today. Because my mom was given 2 years to live, and oh gosh, I'm outside. Was given 2 years to live, and now we're at 13, and so that, and she had triple negative as well. So So, but a couple of different things. One, we are doing research in Africa currently, in 7 different countries, including Nigeria, with Dr. Melissa Davis out of Morehouse. And so we were part of a Grand Cancer Challenge. And so we're studying epigenetics, genomics, and there are like a couple of different work packages to really have to build advocacy into the research from the get. And so let's definitely talk more about this, because I'll be very excited to meet both of you. You met him, you said, but yeah, so let's definitely connect. And then another piece is that, gosh, Hayley said so many things we got to talk about. So the other piece around the genetics, it's so I have a great aunt, grandmother, and mother who had breast cancer. So, but we have no known gene, and I say known gene purposefully because I think it's good to know that like there are so many more genes that have to get to be discovered. So the same doctor who I'm doing this Grand Cancer Challenge with, Dr. Melissa Davis, she has already identified a gene in Ghana that relates triple negative to Black women. Yet that's not a gene yet tested for here. So like there's so much to know and uncover still. So there's that piece as well when you think about how we can be proactive about this. My sister also had a prophylactic mastectomy at this point, and her new boobs look great. But
that's the good one. They remove it and give you brand new ones, better ones, right?
Why not? She had her 3 daughters. She was done breastfeeding, and she was like, "Let's go." And so, but yeah, that's actually how serious we take this. I actually had breast cancer screening at my wedding last year because, like, screen the family. Let's go.
Oh, wow.
You know,
that's amazing.
And then finding like fun, innovative ways to like bring it to the table and have these conversations. And I think it's really important to, and some of the numbers I think to mention, you were talking about earlier, were currently in the US, we have a 3% rate of Black people in clinical trials. So that's like basically zero, you know. And so now we're working with some trials at certain companies. One of them is Genentech. I think in that trial we're now at 8%, right? And so it's like we're just moving the needle little by little, but that's where we're starting from.
I see.
But if you go to whenwetrial.org, you will find our portal. So now we have our own portal for trials, because they were really hard to navigate prior to ours. And so we have a When We Trial training program as well, so we can share this information with other advocates. And then now we have an HCP training as well. So it's like a 30-minute online training, so you can come and learn how we communicate, how to explain trials to Black women.
Yeah, I guess it. So, Dr. Alassane, you were saying something before I kind of stopped you midway and I made a mistake and sent away the
yes, I think I might even hop off if that's okay. But thank you so much for having me.
Thank you. Yeah, and you know what?
Thank you so much.
Share your information, and then we will definitely connect the two.
Yes, we'll connect for sure.
It's really great.
Thank you so much.
Thank you. And send my love to your mom.
Fantastic.
I will. Yeah. No, she'll be so happy.
Yes. Well,
thank you.
You see, yes.
Yeah.
You see, Khuraira, see the beauty listening to these ladies, yeah?
Yeah.
You know, the society.
Yes.
An informed society, very good health system. And this is how you look at triple negative breast cancer patients surviving for over 14 years and counting.
Yes. Yeah, her mother.
And even, and even in the best, even with the best of medical care available over there, they gave her 2-year survival rate.
Yes.
And she's surviving, she's 13, 14 years now.
Yes.
Now, you see, this is our major problem, you know, when you come back home here in low and middle income countries like Nigeria. First of all, the awareness.
Yes. Very important.
The awareness window is huge.
Yes.
People still believe cancer is a cause. People still believe cancer is not a hospital disease.
It's true.
And what do we get? You see, now you can understand the reason why breast cancer is killing our women. Because when you are talking about triple negative, you know, triple negative breast cancer, the way it grows rapidly, more than all other forms of
and they still get people cured, you know, which is amazing.
Exactly. So, but for us here, with all the myths and misconceptions now, the access to care itself is a problem, because first of all, a woman will not even subject herself to screening. You know, that myth of breast cancer is dodgy. So if
Yes.
you allow them to go and give you injection, you will ultimately
You reject it and
what
it will
happens?
kill you. Yes. Yes.
What happens at the end
Yes.
of the day? You see presentation, stage 4 cancer has gone to other organs, and before you know it, patient is dead. This is why, as surprising as it is, breast cancer patients still die in Nigeria. You know, so I truly envy the way things are done over there in America, and of course in other developed countries.
Yeah.
And this is actually our target, because we have to be thinking positively, we have to be optimistic, to be looking at that direction. We want to believe that the healthcare system in our countries all over Africa will improve. We want to see screening services available at primary healthcare facilities, and we want to see community leaders. We want to see the politicians at the grassroots, the councillors, the local government chairmen taking ownership, of cancer awareness.
Yes.
Because if a local government chairman, for example, or a ward councillor,
or maybe
take
the
up
wife, maybe the wife to take
we take up the responsibility of awareness creation. Teaching women how to do self-breast examination.
Yes.
This is one test. This is one basic screening modality that every woman, that every woman can do, regardless of her educational level, if taught how to do it properly. And it's just once in a month, immediately after the menstrual cycle.
Dr. Alassane, can this be taught by a nurse? A nurse can go, like midwives can teach them. They don't have to go to the doctor even, right?
Not even a nurse.
Yeah.
A health educator working in the primary healthcare centers
can teach them.
Can be trained to teach women how to do self-breast examination. And this is an examination you do on your own. This is examination you do is just you in front of your mirror, and once you are used to it, you do it once every month after your menstrual cycle. And once you are used to the normal,
and then
any slight change, any slight change in color, any slight change in the texture of the breast, any slight change in the consistency of the breast, you will know, and you go for medical. Listen to what Hayley Brown was talking about Angelina Jolie. Don't forget, Angelina Jolie had mastectomy because she doesn't want to get cancer.
Yes.
Because she has the family history, so she's not taking any chances.
Yes.
But you have a situation whereby
people don't even know how to find out the family history even, because they will say it's Chiwon-Daji. You understand?
They call it Chiwon-Daji. They don't go to the hospital, so it's not documented.
Yes,
it's not documented. And once it's not documented, see, in my appearance last show during this during a similar show we had last year, I mentioned it. That for the way the projection is for every one cancer patient you see, be rest assured there are hundreds others that have died because they have not gotten access to care. They have not been screened, so there was no diagnosis. Many are dying because of Chiwon-Daji, because of fear of hospital. By the time they get to the hospital, it's already late. And when they die, they say, we said it. We told you not to go. We told you not to go. So we have a lot to do in terms of awareness creation. We have a lot to do because our women are dying.
Yes,
our women are dying.
God, it's sad.
And cancer patients coming to the hospital in the late stages is the common thing you see in Nigeria. Is the common thing.
Wow.
Sometimes you ask yourself, where have you been?
But
that you will leave your breast,
they're
you
not
leave your breast like this to the extent, you know.
You
So
know,
and there is a
they are more worried. They are more worried about native medicine, and they're more
yeah,
worried about voodoo. They're more worried
yeah,
about Tishia than they will be
yeah.
worried about their body. I'm telling you, that's the thing.
That's true.
You-
That's true. But the reality is that the trend is changing.
Yeah,
You
oh God.
know, we are beginning to have, yes, our non-governmental organizations, especially those at the grassroots level, are
Yeah,
trying,
yes.
even though funding is a major issue.
So that is one of
Funding
the
is
things
a
that I
major
wanted
issue.
to ask you about. So, like, if we
Mm.
find like some NGOs that are in the local level that are really passionate, they are trying. Is there any grant that is given to the like the National Cancer Society that can help them in the awareness stage, and not even the treatment? Because if people are able to learn to prevent, you will have nothing to worry about spending money on curing, right?
Yeah,
So do they
yeah.
have that kind of support, or they on their
Well,
own?
well, yes. Well, the good thing about it is this: Nigeria, for the first time, has a national institute. The National Institute for Cancer Research and Treatment is
Yes,
everything cancer under one roof.
wonderful.
Now,
And
in
where is
that,
that
in
located?
that is headquartered in Abuja.
Okay, wonderful. Which is
It's
central.
headquartered in Abuja.
Yeah.
Yes, but of course, it's a national institute that is just about a year old, and of course, you expect the institute to expand. Already, the institute is working with all tertiary health institutions in the country, and
Wow.
of course, particularly our cancer centers.
Okay.
Just recently, there was a national launch of national cancer, population-based cancer registry
Yeah.
that was unveiled by the minister. At that event, cancer in Nigeria is now a national notifiable disease.
Wonderful.
Because when you have population-based cancer registries, population-based cancer registries are cancer registries that collect data not only from the hospitals but
Yeah.
even from the community. For example, an NGO that is working in a rural area has and is collecting data, has the leverage of getting that data to be processed or to be channeled through the population-based cancer registry in that area. So now, with the National Institute for Cancer Research and Treatment, the primary target, of course, is prevention. And there is a whole directorate on prevention and cancer control at the National Institute.
Wow.
And as advocates that believe in prevention being better, cheaper, and safer than cure, we
Yeah.
believe that preventive services, health promotion uh, services needs to be made available to the grassroots. Now,
Yes.
this institute is expected that over time will have a coordinated mechanism across all the zones, present in all the zones, will be present through the cancer institutes, through the cancer centers, will be available through the tertiary health institutions, so that it will be all over the country, so that there will be a holistic and coordinated manner of awareness creation. There will be a holistic approach at enshrining screening services at the level of the primary health care. Already, the institute is thinking of establishing a cancer screening center in each of the geopolitical zones, because
And
it's only when you detect early,
yeah.
that
Yeah.
you get complete cure. And breast cancer being the number one killer of our women is
Yeah.
highly preventable
That is
and highly treatable when detected early.
yeah. Yeah.
There is a cancer survivor in my dear state of Yobe, one Hadiza Aliyu Manga. She has an NGO and is doing very well in terms of grassroots reach, in
Yes.
terms of reaching the rural communities.
Yes.
She has
Yes.
been consistently doing cancer work every year to create
Yeah.
awareness about breast cancer. In
Yeah.
fact, on several occasions, she has done uh, mini fundraising sort of
Yes.
to help cancer patients.
That
So
is where
if organizations,
that's where I was gonna
yes,
come in. I'll tell you the story of triple negative breast cancer that Hayley was talking. I actually was the first person that did the first, one of the first people that did their fundraiser. And they do
oh,
this a lot with different vendors, business owners, and then they do their annual gala. That helps
mm,
a lot of what they do. They get money to transport those that don't have the money to
yeah,
go for their chemo. And I know like how are people like Biki now. So is there no, I'm serious. You know how are people? If everything about Nigeria, if you make it fashionable, if you will create a gala, like I don't know if
yeah,
National Cancer Society of Nigeria is doing an annual gala, but if they
yeah,
will introduce an annual gala that is one for the national and one for the state chapters, and what you're talking about in regard to the commissioner, the governor, the local government chairman, maybe the first lady will champion it or whoever will champion it, but they do their gala, and that gala, that is where people they will raise money to support those people in the rural areas that have smaller NGOs that don't have a means to do it. This I'm
sure,
going to tell you, I was reading triple negative digest, they have raised over $50 million in the 15 years that they've been doing. And all they are doing is they're reaching out to organization, to business owners, and they're doing their galas and also
mm,
doing some of the walks, you know. So I'm thinking, honestly, of course, I'm sure, I don't know about grants, but I'm sure with what they have accomplished, they have done
yeah,
so much. And
sure.
and it will give them another leverage in getting a
That's
grant.
true. That's
But
true.
I think that
That's
our
true.
people need to start thinking in that mindset that even the
Sure.
local government chairman wife can do her own local event where she's
Yeah.
inviting the people in the local area to even bake things and sell small money they collect. They can pay the transportation of the help. No, it's certain. I mean, you don't have to work for that all the
You
time.
see, you see the problem with low and middle income countries like Nigeria is not like in the US, that kind of community, kind of community gala you see where people will bring things out to auction. Yeah, and then everybody freely, buying juice, dropping. The problem with Nigeria
Yes.
is that 65% or more are living below the poverty line.
True. True.
65% or more of the of the population are in rural areas with no form of formal education. Now, with 80 to 85% of out-of-pocket expenditure, people paying for healthcare out of their pocket, unlike over there,
Yeah.
where there is very good insurance, health system is good. You are
Yeah.
sick, you just
Yeah.
call ambulance and lie down, they will come and carry you to the hospital. In this, in places, in places like ours, the
Yeah.
problem, the problem is how to buy the tomato and the the gari that will be
Okay,
cooked for dinner
I
that
understand.
day.
Okay, it's a there.
People,
The picture
people
is
are
full.
hungry. People are hungry. You
Yeah.
understand? So, so that is actually the problem with the community awareness. That is the problem with that kind of community gala or whatever. But now there is an initiative I want to bring up as chairman of the National Committee on Oncology and Cancer Care of the NMA. We
Okay.
have been working NMA since the time I was vice president, has been working very closely with the Nigerian Cancer Society. Now, the Nigerian Cancer Society has branches in all the states.
Yes.
The member organizations are present spread across the nation in all the states.
Okay.
Now, the Nigerian Medical Association is equally present in all the states. with a state chairman in each state and the FCT.
Yeah.
Now, my committee will have a state coordinator in each state.
Wonderful.
We already have 6 regional leads. We have
Okay.
1 regional coordinator in each of the zones. Now,
Yeah.
what I want us to start doing, at least monthly or quarterly, in
Yeah.
every state, is through that state coordinator
Yeah.
and the regional lead of that zone, and of course the Nigerian Cancer Society chairman of that state, to
Mhm.
identify one community,
Okay. Okay.
get 1 or 2 doctors, 1 or 2 nurses, and then we go and create awareness.
Okay.
We will make it routine. When we
Yes.
have one, if we cannot do it monthly, we do it like every quarter, and then
Yes.
we do it all over the country.
Yes. That would be really
And then,
helpful.
yes, and
Yeah.
by the time, over time, the impact will begin to come out. But again, another still problem is that, will people listen? Because the people are struggling to put food on their tables, and they may not be ready to listen to you.
But
Moreover, when you come to talk about Daji,
yeah, but
you know,
I think having survivors to speak up can help because
very
I
important.
yeah, because if they see someone that looks like them, that
Yeah,
is but our people, they don't want to tell anybody they had cancer and survived.
that
So
is another problem.
yes, because
But
they don't
but we
want.
have we have many of them. We have many of them coming out
Good.
and positively living with cancer. In fact, let me tell
That
you
is
this.
exactly.
This year, this October, the quantum of awareness creation that is currently ongoing all over the country, I am beginning to believe
That
that
it
we
will.
are going to get there someday, by virtue of the fact that I'm the president of the Nigerian Cancer Society, and
You honestly.
without preaching to my people in the village, they have subconsciously now agreed that cancer is a disease that needs to be detected, that
Yeah.
cancer is a disease that needs to be treated. Not that every single thing you see that is odd, you say it
Yeah.
is dodgy.
No,
You
no.
wake up, you have a swollen breast. That is just ordinary,
Angie,
probably uh, mastitis. You say it's dodgy. And instead of you to go to the hospital and get antibiotic and analgesic that will take away that pain and take away the inflammation, you stay at home. And before you know it, one gland somewhere has
spread,
started
spread.
something else, and before you know it, one cell has started to misbehave, and before you know it, already you have family history. And with this now, before you know it, infection has set in. Before you know it, the cells of the area have degenerated, and before you know it, it's cancer.
Hmm. Hmm.
And they will
So,
bring a traditional concoction today. They will come and pray for you tomorrow. They will take you to this boca the next day. Before you know it, cancer has become stage 2, 3, 4.
but do you
And by
think
the time they are taking you, by the time they are taking that woman to the hospital, it's not the breast cancer, oh, it's anemia. Her blood has finished. The
oh,
cancer cells, the cancer cells have eaten all her blood. And it is that loss of blood that she's lethargic, she cannot
big,
work, she has
yes,
to be supported.
yes,
That is when they take her to the hospital. When they take her to the hospital, the doctors will be struggling to get blood to
blood,
give her, so that she can be
have
revived.
the
The
strength.
cancer is even secondary at that stage. So many of them, before you even begin to revive them and talk about treatment of the cancer, they are gone, because by the time they come, they are already terminally ill,
Wow. So in the
because
case
of the
that
complication of the cancer.
yeah, in the case that they're talking about, I'm so happy that at least there is someone doing where they're beginning to do the trial, the clinical trials in
Yes,
Nigeria. So how is it?
yes.
Is it um, in one locale, or is it now a national thing too? I mean, people have access to that form to fill out, or you are still even trying to convince them to understand they have cancer, to less of saying you should go to clinical trial. So that is a challenge, right? In order for you to even tell someone to go and fill form for clinical trial, you need to convince them that cancer is actually a disease that can be cured. You know, so I think that that's the challenge now. The challenge is the awareness first that the cancer can be cured if you catch it early. So
true.
yeah,
And that is our major challenge. That is our major challenge as advocates,
yeah,
because the myths and misconceptions out there are enormous, are so overwhelming. And once we can create a significant headway in trying to convince people that cancer is real and cancer is not a taboo, you are not being caused by any Kishia if you have cancer, and cancer can be prevented.
Yeah.
And of course, when you detect it early, it's easy.
Yes.
You know, when you detect it early, you can treat it.
Yes.
And that is actually our target, and we will continue to push the agenda. We will continue to push the narrative of prevention, and of course, pray that we will get somewhere.
Yes.
But the reality is that government must also do the needful.
Yes.
Because without the conducive environment, I was saying earlier, the health system over there is so sophisticated to us. It may not be perfect to you people over there.
Yes.
But to us, it's so sophisticated, it's so well coordinated and organized that access to healthcare is not a problem.
No.
In places like Nigeria, access to healthcare is a problem. And how do you ensure access to particularly screening services?
Only the government.
Ensure that you have mammography. Yes. How do you ensure that you have mammography machines in all primary healthcare centers in Nigeria? There are many states that don't have mammography machines, even in their general hospitals, talk less of primary healthcare. So how do we?
Yeah.
Sorry?
So how about like right now, in case like you guys have a relationship with some of these international NGOs, and we're able to secure, you know how like the hospital change their mammography machines every 5 years, but it's still a good one. If we would be able like to talk to them to get us some of these things, would the government be able to waive the importation fee and help with the importation of the machine, because the machines are expensive? But maybe if we discuss this with some of this international NGO, they might even say, okay, there's a hospital that, you know, every year every 5 years they change the machine, but it's not that the machine is bad. It's just that's what it is here. It's like here, hospital beds, you know, certain number of years they don't want those beds they bring, but the bed now they're finding a place to put them. I remember a lady in Boston that was getting those things, even like the outfit for like the doctors and what have you. But when they come to the country to bring it in, they will pay for the shipping. But when they get there, they put so much tariff that they end up leaving it at the port. So
that is another major issue again. That as advocates, we don't just stop at telling government to do the needful. We'll also try to point out that there are several instances where free diabetic medicines have expired at the port because of the clearance issue. There are several instances where medicines have expired at the port, and I think government is not unaware of that. And as advocates, again, we will push particularly, you know, for cancer equipments. And I think the general commitment especially now that we have a coordinated system of cancer management in the country, with the National Cancer Control Program and the Nuclear Medicine Department at the Ministry of Health. It's responsible for policy decisions, for policy direction, and of course the National Institute for Cancer Research and Treatment. I think this is an area that we'll pay more attention to now with our international collaboration, so that we can have these machines. Look at almost all the ATM machines you see in Nigeria are second-hand ATM machines brought in from outside, and they come here as new. So most of these machines, you see, as far as we are concerned here, they are new and they can function effectively. So like I was saying, to ensure that we have proper training of health educators at the level of the primary health care, to ensure that we have proper screening equipment at the level of the primary health care center. We need to fund the health system.
Sure, very much.
We need to at least achieve the minimum of the Abuja Declaration of 2001, where all African countries agreed that 15% consolidated budget should go to healthcare. We have been dribbling between 5 to 6% every year since 2001.
Wow.
So what are we talking about? If we are truly serious and we want to see revamp the primary healthcare system, then we need to pump money into the healthcare system.
So how is this?
We need to prioritize.
How is this new national insurance thing that they introduced going to help the system, you think? How is it going to help?
Very good. Very good. Very good. You see, now, problem with Nigeria is that most of the time, health is on the, what do you call it? The concurrent list.
Okay.
And health, federal government can decide on what they need to do, but they cannot dictate to the states.
Okay, I see.
The state, the state. So that was actually the initial problem we had with the health insurance.
Okay.
There is health insurance at the level of the federal, but only federal government workers are enjoying it. Now, until when the Basic Healthcare Provision Fund came up, when 1% of the consolidated national budget is put into a basket for provision
1%? 1%
of the 1% of the consolidated budget.
Yeah.
1% of the consolidated budget is put into a basket, for that basic healthcare provision fund. Now, that fund is responsible for provision of healthcare to the most vulnerable in the society.
Okay.
And that fund is supposed to be channeled through the primary healthcare pathway. And that was when it became necessary, it became compulsory for state governments to establish state health insurance schemes.
Okay.
And as we are talking here, because of that money coming from federal, every state in Nigeria has health insurance scheme. Now, last year, the National Health Insurance Scheme, the National Health Insurance Scheme Act was amended.
Okay.
It's now National Health Insurance Authority.
Okay.
Now, in the new act, health insurance in Nigeria is now compulsory.
It has to.
Health insurance is compulsory, but implementation is where we have the issue. When you look at how many percentage of Nigerians are covered, you discover that it's a very negligible percentage. Why? Because you cannot put the law into action without providing the necessary environment, without providing the adequate funding. And then again, the health insurance is centered around civil servants. It's only the elites or those that are aware amongst the people, that the population that is not in the government working class, for them to go and pay for insurance. For example, with 15,000 naira, you can pay for insurance annually.
Yeah,
when you pay 15,000 naira, you enroll into the health insurance. At the end of the day, if you are the type that falls sick frequently, the government will spend over 300,000 or even 500,000 on you.
Yes.
So, but efforts have to be made to reach the informal sector.
Yes.
Efforts must be made by the National Health Insurance Authority and by the state health insurance agencies to reach the people selling OSEI, to reach the people at the grassroots, to reach the cattle rearers in the hamlets, in the bush, to reach each and every Nigerian, so that there will be adequate community acceptance, so that people will enroll into the health insurance, so that we can all be covered. There is a provision in the new act. According to the act, over 72 million Nigerians in the vulnerable age group will be lifted or will be covered under insurance. How do you do that? How do you achieve that? It's by putting in more funding. When you put in more funding for healthcare, you have adequate coverage. So we are very far from the promised land, but we cannot say we are not making progress.
We're making progress.
And
so
as advocates, not only for cancer, for the entire gamut of healthcare, without universal health coverage, we cannot achieve anything.
No.
And it's only through
this country, people they have to push for universal coverage. Even here, that is advanced, and you have to show.
Yes, and it's only through health insurance cover that you can achieve universal health coverage for all Nigerians. And for
I take it back. Not universal coverage. We have affordable care, so it's subsidized. So that depending on the income level of the family, So if you have money, you can go and buy whatever. But if you are low income, it's subsidized to maybe like what you are talking about. The 15,000, I'm sure, some middle class, a lot of the middle class people can afford it, And if the money is used rightly and it can be reinvested so that it can multiply and even cover those people that don't have anything. But unfortunately, how sure are we the money will be used for what it is formed for? So our last thing before we leave, please talk to us about your new office, what we will be expecting from your office, and all of those good stuff. Congratulations.
Yes, thank you very much. Thank you so much. Thank you so much. I have been in the cancer advocacy space and a member of the Nigerian Cancer Society for at least 22 years now. Wow. I started during my period as a medical student when one of our professors at the time became the president of the Nigerian Cancer Society, Professor King David Tenayawe. He's still very strong and agile and actively participating in activities.
He must be so proud to see one of his students.
Oh yes. There was a contest 2 years ago by the Union for International Cancer Control for member organizations to nominate their role models, their heroes, people that inspired them to go into cancer advocacy, and I gladly nominated him. Without his knowledge, I gladly nominated him. So when the list, I think about seven of them globally were listed on the website.
Wow.
As inspirational leaders. He was so touched, when he saw it. So I became a member of the society when I was in medical school, and I have been very consistent ever since. And I became vice president about 6 years ago. I served as vice president for 2 years, then served as, at the time I was serving as vice president, I finished, I was a vice president of the Nigerian Medical Association, then became vice president of the Nigerian Cancer Society. Then after that I became the president. I served my first tenure. I'm serving my second tenure now, and by the grace and power of God, I will be handing over this year. We have the International Cancer Week that we are commencing on Monday. The International Cancer Week is a one-week event, and it will culminate with the annual general meeting of the Nigerian Cancer Society on Friday next week. And on Saturday, we have our fantastic dinner where I will be decorating a new president by the grace of God.
Wow.
Now, the beauty of my new office, as the chairman NMA Committee on Oncology and Cancer Care, is the fact that those that occupied the office before me are all members of the Nigerian Cancer Society. They are doctors and they are members of the Nigerian Cancer Society. So one, there is continuity, and then we have equally been partnering with them. I remember when there were two chairmen when I served as president of the Nigerian Cancer Society. Two chairmen that served for 2 years. We have had activities at the national level and at the local level in collaboration together. So that relationship is going to continue. That relationship is going to be more energized. That relationship is going to be more robust. Like I said, so many programs, so many initiatives that will bring up will have the partnership, the collaborative component well emphasized, because partnership is key. Working together is key that will get us somewhere. So by the grace and power of God, when I hand over as president, I'll be there as immediate past president, but I will want to delve further deeply now into my new role as the NMA Committee Chairman on Oncology and Cancer Care. And we work closely with the Nigerian Cancer Society, all partner organizations. The good thing about it is that as the chairman of the NMA National Committee on Oncology and Cancer Care, all the oncologists, all the doctors treating cancer in Nigeria are my members. The same way they are my members now. As
also
of the Nigerian Cancer Society.
Good.
You see that? So by the grace and power of God, we want to carry out a lot of researches to identify a lot of factors that are responsible, especially factors that are bedeviling acceptance of cancer screening services at the grassroots. We want to demystify these myths and misconceptions. We want to identify the core reasons so that we can address them head on.
Yes, I think that is the key, the awareness and also continuity, because a lot of the time, some people, when they bring somebody, they want to introduce their new thing and they will stop the other things that are being done. And that is setting you another 5 years behind. So being able to continue working and moving forward will actually help and make it easier for you guys to reach your targets. So Dr. Alison, as always, we are very, very happy to always have you on Dialogue with Khuraira. We're happy with and proud of you for what you are doing for the betterment of humanity, you know, especially in the breast cancer space. You know, I know you make a fun of the thing menene daji, maganin jefin daji, but I know it hurts you. It hurts you a lot because
it's a serious matter.
As a doctor, is like you just humanize it, but you just want to open your head and say, please wake up. This is not jefin daji. It's real. And you know, I wish you and your team and the rest of the other NGOs that are working with you guys all the best. And God willing, we will make sure how we see this, the three of you that were here earlier, collaborating somehow to help a lot of the people that really, really needs the assistance that can help them save their life. Because, you know, losing someone with cancer, you're not just losing that person, you're losing a part of a whole community. You know, a family suffers, many people suffer because of that. Sometimes, like you said, with the triple negative breast cancer, it happens, you think like it's a boom, the person is gone. They are not even prepared but all because there's no awareness on how to
Yes.
detect it early.
Yes.
And I know
Yes.
that with your good office and many people that are working with you, a lot of change will come in that parameter. So thank you so much. I know it's late over there. Have a wonderful night, and
Thank
we
you. Thank
yeah.
you so
All right.
much. Thank you so
Thank
much
you.
for all you do. Thank you so much for the
No
impact you are
problem.
creating.
It's
Oh,
really, really
thank
good.
you.
Thank you
Thank
so
you.
much for support. Thank you. Bye bye.
Thank you. Bye.